so that we can curb the disease progress that is going on with the kind of cancers and various other chronic diseases on the rise. I think that is something that we all actually have to look at. Whether we belong to the hospital industry, whether we belong to the provider industry, whether we belong to accumulators, aggregators, or whichever part, innovators, I think we all actually need to look at preventive health in a big way. So I'm glad we have everybody here now, I think. Is someone still missing? I think, yeah, Dr. Shiban is still not there. Dr. Shiban is missing, I think. Dr. Shiban Ganju is still. Okay, sure. So we are on to our next session, which is Achieving Universal Health Coverage, Insurance-Led Innovations in Ayush. So the recent policy aiming at universal health coverage, launch of Ayushman Bharat, as you all know, Ministry of Ayush are some of the key steps of Government of India. Insurance-led innovations can come from market and state actors both. This session deliberates on possible ideas to further strengthen the Indian healthcare system, what we can learn from other markets like NHS, and what can the insurance sector offer. What can the new care delivery models such as home healthcare offer, and possibilities with alternative medicine and treatment lines? To help us understand the process of innovation in healthcare, it is critical to answer the question, what is the catalyst for healthcare innovation? In other words, does innovation chase need, or needs chase innovation? So I leave it. Should I invite the keynote speaker first? May I invite Dr. James P. Kingsland to... Would you? We could start with you, sir. So if you could say a few words, and then I'll leave it to the moderator to please take the session forward. Thank you.
Many thanks, and good afternoon, everybody. I'm a general practitioner working in the NHS in the north of England. I've sometimes wondered how to qualify yourself, because when you get to a certain maturity, you talk about how long you've been in the service as opposed to what you've achieved in the service. But I've been a general practitioner for 30 years now, but I was thinking to qualify it, I think that's, I've been a general practitioner for 250,000 consultations. So hopefully that's given me the insight to present what I'm going to be talking about the development of primary care in principle. I'm also president of an organisation called the National Association of Primary Care. This is an organisation that is UK-wide and looks after the interests of primary carers, and I'll explain a bit more about what we mean by primary care, but it's usually the contractor services working in the community, pharmacy, dental services, sensory services, optometry, hearing services, as well as general practice. But it helps our colleagues do their job better, put policy into practice. And we do a lot of policy development, one of which I'll be just touching on, because I appreciate I've got a lot to get through in a relatively short time. And finally, just to give some academic background, I'm a professor of primary care at the University of Central Lancashire, which is looking at some of the evidence base. I've worked in our Department of Health for 2 sessions, both of 4 years, and sometimes policy has an evidence vacuum to it. So we're trying to build what we're saying and demonstrating with a strong evidence base. So my exam question was, how do we achieve universal health coverage? And I've started by saying there's nothing new. In a lot of policy I've been involved in, sometimes by the time you've described it, a service is already delivering it. So my first thing is there anything new in the ambition to achieve universal health coverage? And I know we're focusing on India, and I've thought about some comments that I often use, particularly with policy development in the NHS. There's nothing new except what has been forgotten. Interesting comment. Do you know who said that? It's often attributed to many people. It was thought to be Marie Antoinette, talking about fashion, I think, but it was about saying the principles that has there anything new been developed. And the next one from the Christian Bible, Ecclesiastes, saying there's chapter 1, verse 9 for anyone who's interested, but there's nothing new under the sun. What has been will come again. And then the final of these 3 quotes, which is probably more appropriate for India, but this goes back over 2,000 years, and I thought it was a really interesting quote from Emperor Ashoka, who you well know, but I understand there's lots of rock columns that have been discovered around India, the major rock edict, one of which was saying that the propagation throughout the Kingdom of India to completely give accessibility to good health was an ethical responsibility. So to put it into context, I don't think there's anything new about the ambition of achieving universal health coverage, and probably if we go to a more recent timeline, since the 70s. Oh. Okay, we'll start again. Good afternoon. My name is James King. I think we've. So you've not even seen my previous slides, I guess. So have these not been seen? They weren't coming up. Oh well. There we go. These were the quotes. I was told never to work with animals, children, or PowerPoint when you're on stage, because something goes wrong. So for those who want the quotes, there they are again. But so the more recent timeline is that in the 70s, the WHO first started to talk about health for all. And it was interesting that the ambition in 1977 for health for all was that we would achieve that universally by 2000. Of course, by 2000, when it's not achieved, the United Nations started to talk about Millennium Development Goals, and they were going to be delivered within 15 years. When that wasn't quite achieved, we had in 2016 the SDGs, which we're still working towards and have a target of 2030 to deliver this by all member countries. And the SDGs, like Ashoka, was saying that we need to advocate universal health coverage. So it's to set the scene that let's not think we've got to do something dramatically new. We've got to invent a lot of new things. We've got to reflect on history, build on the best, look at international evidence around how we develop systems of care, but for once, make it sustainable. I think that's the challenge, not necessarily to develop lots of new ideas about how to deliver healthcare. But we may need to revisit a 70-year-old definition of health in the context of today's society. Because WHO, of course, talk about the complete physical, mental, and social well-being. But certainly in my practice, and I think we see more and more internationally, that the wider determinants of health, I see in my surgery now that people, many of them who need care, often need a job, a home, and a friend. And if they had all three, their ability to self-care, some of the things we're challenged about, would be far enhanced. And probably when ill health befalls them, if they've got that social network, the fact they've got a good social environment, they would deal so much better with their health. So we need to build in the wider determinants of health, and not least the environmental and climatic health. I was talking to a colleague. I do some primary care work for a faculty that is developing throughout India for disaster medicine. In fact, I'm going to Pune on Sunday to talk about the primary care aspects of the preparedness, which sometimes is lacking, not the expertise that when the disaster happens, the response teams are often well knowledgeable about dealing with it, but particularly the recovery, the reablement of society, the back to better for societies that can suffer for many years post-disaster, which sometimes isn't really looked at, but really important to have a strong primary care system. And the rest is well known, nutrition, sanitation. So should we be looking at the WHO definition as a state of complete physical, mental, social, and environmental well-being, including the absence of determinants of disease which can cause harm? Really important to build those into any new system of care. And I make no apologies, therefore, about the definition of the system which I think delivers the greatest efficiency, sometimes better outcomes, and certainly drives down per capita costs in healthcare systems. I was saying earlier, in the NHS, we look at primary care as a level in the system. We have 4 contractor services, which is delivering extended services within a community. But to deliver primary care, it's got to be where patients first access care, there is a comprehensive, holistic service and a continuum that delivers most against that need. We then use our hospital services. I am a non-executive director of the Royal Liverpool Hospital in my neck of the woods, so this is not a case of sectors against each other, but recognising that our precious hospital services need to be supported, but they will be best supported by allowing people to have episodic care, for short episodes of care, for high tech, only when it's needed. And I think internationally I see our hospitals are overloaded with sometimes people needing care, but not of that particular sector. So the comprehensive care that is needed by the population, the coordination of care and the integration of health and the wider determinants, and then the gatekeeping role that allows hospitals to only see those people who really, really need hospital care is how I see and how we certainly from the NAPC define primary care. If we're going to build any healthcare system, the IHI, you've probably heard of the IHI based in the Institute for Healthcare Improvement in Boston, Massachusetts. We usually draw their machinations like a gun to say, you know, what are they thinking? But they came up with the triple aim of any healthcare system, that any healthcare system needs to improve the health and well-being of a defined population health management by looking at the early detection, the screening, the preventative aspect of care, but not forgetting the personalisation of care and balancing that with improving the individual's experience and outcomes and reducing the per capita costs. And I was saying that all the evidence around reducing per capita costs in healthcare systems is by having a strong system of primary care. But also what we're finding, certainly in the NHS at the moment, and I was at a primary care facility in Delhi this morning, where they were talking about recruitment and retention, some of the stresses that are in the service. And if we don't focus on improving the experience of those providers of care, the enjoyment of clinical practice, we might have the hemorrhaging of clinicians, as we are seeing in the NHS at the moment. And one of our biggest financial risks, I think probably the biggest financial risk facing the National Health Service of Great Britain, is the morale of the staff. If we don't get that right, we may never deliver the efficiencies that we're trying to drive, and the efficiencies that Ayushman Bharat are probably looking for that extra investment. Our evidence, and Chairman, as I say, I can get quite garrulous on this subject, so I appreciate I've only got 15 minutes, so please pull the mic when you've had enough, but I'll just give some of the evidence. This evidence is from the US. It goes back to the 70s. You've probably heard of Barbara Starfield, sadly no longer with us, but a paediatrician, interestingly, out of the Johns Hopkins in America, who first started to look at the evidence base behind primary care. And I've only picked out something from the papers which do say that if you've got a strong system of primary care, you get better access to services, better equity, and improve cost effectiveness. And particularly, if we're going to drive down health inequalities, if we're going to make improvements in outcomes, then we need to deliver most of the care in the community sector, because we do know that hospital specialties, vital as they are, who do really important disease-focused work, do not make any effect. In fact, they probably heighten health inequalities for those who can access that care. Again, if we're talking about from the patient's perspective, the evidence shows that people in communities, and this is not just based on England, what they value, this is an international study, is fairly consistent. Continuity of care, a range of services at that first contact, not episodic. They want to know about the technical competence, but it's about the communication skills, how accessible it is, and the personalisation of their care, which delivers better outcomes. And finally, because having looked at some of the primary healthcare facility development in India, interesting that I think there's 26,000 of these services, but over 60% of them only have just one physician who sometimes is expected to deliver care to a 50,000 population. I think almost 10% don't have any physicians at all, and very few of them work on team-based care, which is a cornerstone of primary care delivery. The benefits of team working, again, I won't go through this, but we have evidence that team-based approach, delivering a holistic care, the right care by the right person. And in this team I saw in Delhi, I had one facility, and on the ground floor there was a dental service. Just down the corridor there was a service for musculoskeletal physiotherapy. Further up there was a nursing service, a community nursing service and an outreach service, as well as community physicians. And on the top floor they had a laboratory for point-of-care testing, immediate response to things that would be required to finish an episode of care. So we know that the team-based working approach does reduce errors, it improves quality, it improves safety, and we've even got some evidence now that it lowers mortality when there is an approach which isn't just uni-focused to one specialist. Chairman, are we okay to... Okay. So finally putting that into a concept, and very briefly, bringing all that evidence together, how do we have a sustainable health system? And I'll just touch a little bit on the NHS, because we've had a primary care system since the NHS was created in 1948. It is still the system where 90% of all contacts within our NHS is within primary care. And those 90% of contacts is delivered for less than 10% of the total budget, the £120 billion that is spent on healthcare in the NHS. So where would you look to invest if you wanted to increase efficiency, outcomes, and drive down per capita costs? So we've had this traditional general practice, a registration process, a community registers with this primary care facility, and it's done us well for the 70 years. But we're saying, based on a team-based approach, population health management, building on what we know, we may need to scale this to a size that can do the evaluation of population health need and build teams, whole-time equivalents, to deliver an extended range of services in the sector, which I feel a little bit uncomfortable. We're calling it now the out-of-hospital sector. I started in general practice, then went into primary care, and now I'm designated out-of-hospital sector. It does feel as though, and I think when we come to the discussions, it feels as though we have the mothership, the hospital, which must be protected, and all our services and focus. And then there's this strange sector called out-of-hospital sector that should actually do most of the care in a coordinated way. So we're saying that the primary care home concept is where we're going to build on the experience, not invent anything new, but build on the knowledge that we can build a concept where we've got 4 characteristics to the primary care home. This is very similar to the patient-centered medical home that is in the US. There's some very similar concepts I've seen in Denmark, in Sweden. The principles are the same, balancing population health management with the personalisation of care, developing a multi-professional workforce to deliver against that identified need, aligning the financial and clinical drivers. That means that the clinicians take ownership of the budgets that local population is utilising, and driving down the costs by cutting out waste, duplication, unnecessary hospital visits, and thinking about how best to deploy resources. And we find that all of that works if you put all that together, particularly the team and team-based working that says working as one team, the cognitive level at which people can work together. And time won't allow me to go into the detail, but we know it's about between 100 and 200 people can work on a basis where they know each other's names, their skills and competencies, and can drive the efficiency by working as one team. And we've mapped that back onto what a population could be served by that team, and it comes to about 30 to 50,000. So we're saying that the unit for the primary care structure is around a population base of 30 to 50,000, and you can deliver a team-based approach, the analytics of that population that makes some sense, and still deliver personalised care and local care where people can access within their community. Is it all pie in the sky? Well, to date, our primary care home is spread now to cover 9 million. I know it's relatively small at the moment, but 9 million people in England are being served by a developing primary care home, building in all of this evidence. So at the moment, we've got about 1,000 of our general practices involved, covering 16% of the population. That just gives a spread. but our governing body, NHS England, has said, now can we get complete national coverage? We are having close association with the US at the moment. I'm going to be over in the States in about a month's time with their patient-centred primary care collaborative. This is the organisation that looks after primary care development and aligning some of our experience and learning. And hopefully today, because Chairman, I'll take a breath there, it's given a flavour of how the principles of a strong system of primary care can be built into any health economy with a strong evidence base and deliver what I think Ayushman, which we'll be talking about, is going to be trying to deliver in India. Chairman, thank you for that point.
So, Dr. Kingsland, before you leave the stage, this is a great concept, primary care home. You've implemented this with the NHS. You went to a primary care facility in India today. Now, India is a diverse country. We've got a large population, low per capita income, low ticket sizes. How do we embrace a concept of this? How do we bring this to India? What would be the changes needed to bring this to India?
Well, what I was trying to say again is there's nothing new, hopefully, in some of the concepts of what I've said, maybe the detail. And I think for what I've seen in some of the primary care developments in India, they are working already. It's how do you systemize them? How do you create adoption? And some probably the reasons why reforms fail, the cultural change that society then says, this is the sort of service I'm going to use, rather than say, well, I always want to go to my hospital. If I've got a headache, I've got to go to the ER. And if I want to have a blood test, I'm going to buy it whether I need it or not. So there's got to be a cultural shift, a sense of building on what is established, exploring what's established in your own service, because there's some fantastic primary care facilities, but it's not systemized, it's sporadic, there's small islands, and I saw a great island within Delhi, but it's only for the few at the moment. But I don't think importing lock, stock and barrel for another health system, do not import the NHS and its bureaucracy, but some aspects of the learning, and if we learn from international evidence and build a strong evidence base, we might just create systems, and hopefully, if I'm allowed, I'll be helping with some of the developments that I saw this morning in India too.
Thank you.
Thank you.
So when Sachin and I spoke about this conference a few months ago, Sachin Gaur, I told him the entire conference should be about Ayushman Bharat. Because if we really think about a large scheme, there are lots of schemes that come out in India, but in India, this year, an election year, this is about something as big as anybody could have announced, right? And the panelists, we were all talking earlier about Ayushman Bharat, everybody's got an opinion. We all understand that if you talk about a universal health coverage, Ayushman Bharat is a big step from the government side in terms of commitment. We all understand structurally a lot of things have to be changed. So a large part of the discussion today, we do want to talk about that scheme too, and have everybody give their opinion itself. But before I do that, I want to just go across and introduce everybody. Dr. Kingsland's been introduced. Really quickly, Dr. Ganju, he's the chairman of Atrimed Pharmaceuticals and founder at Save a Mother Foundation. By the way, Dr. Ganju's Save a Mother Foundation, you all got to check out the website. Amazing work. Would love to actually spend maybe a couple of minutes later just having you talk about what you've done there too, Dr. Ganju. I've got here Dr. Ram Gulati, who's a consultant dermatologist with SDM Hospital, Jaipur. I've got Dr. Dhakal, who's the founder and CEO of Health at Home Foundation, Nepal. And then we've got Mr. Ramani, who's the head of product and innovation at Policybazaar. So we also got a strong insurance perspective. Thanks. Now, just really starting off, back to Ayushman Bharat. So scheme, one of the largest of its kind getting launched in the world. We are saying we're going to cover 100 million poor and vulnerable families. That equates to 500 million Indians that are going to get covered within the scheme itself. From having announced it a few months ago, there's been a rapid pace at which the government's been announcing how they'll actually implement it on the ground, including finally launching it on September 25th itself, right? Now, Ayushman Bharat is the step towards universal health coverage. We've had RSBY in the past. We've got government schemes such as CGHS. We've got ESI that have been health protection or insurance schemes itself. Now, Ayushman Bharat, the goal as a government is stating is to bring these all together into a single scheme that'll operate pan-India. We've set up a national health authority at the center that'll be governing the scheme, but there will also be state health authorities at the state level which will be responsible for the actual implementation itself. Now, I think we should all, with the panel, we've all got different areas of expertise, just go through and say, if you were advising the Indian government on the Ayushman Bharat scheme, based on your area of expertise, number one, what would you say are the key challenges that the government should anticipate in the next couple of years? And number two, what key suggestions would you make to the government to make sure that the health insurance scheme, this particular scheme, health protection scheme, actually succeeds in the future itself? So first, let me hand over the mic to Dr. Ganju.
Thank you. First, since you asked me about Save a Mother, let me spend 30 seconds on that, and then I'll come to your question, if you please. Save a Mother, as the name signifies, we enter the poorest of the poor areas in rural India where 60 to 70% population lives. Now, India lives at least in 4 kind of strata or 4 different centuries. One is the information age people that are in this room, which are very different from the next stage, which is the industrial age people that, serve us the moment you step out of this hotel. And number 3 is the agricultural people who's still about 3 centuries behind. And the 4th is who have none of the above. They have no education, they have no assets, they have no talent. And huge number of them are utterly poor. The key is, how do you design a health system for all the above, especially the bottom of the pyramid, and you really have to go there to see them, to visit them, which is what I do at least half my life. Save a Mother, entry strategies, maternal mortality reduction. We seek poorest of the poor. We work in 1,100 villages, cover 3 million people in 4 different districts of India, including a Maoist district, to see whether these ideas work. Fast forward, our results have been the following. In Gadag district in northern Karnataka, a wretched poor district, people have no money. We started this project of maternal mortality reduction 5 years ago. MMR at that time was about 400 or so, which is published data. Our own survey was slightly higher than that. MMR is defined as mothers dying of childbirth per 100,000 population. It was about 400 at that time. Fast forward, last 24 months, in Gadag district, 167 villages, close to 1 million population, there's not been a single death. No mother has died. Our infant mortality rate, US is 4, ours is 6, which is number of infants dying in first year of life. Cost is 25 cents. I say 25, the truth is 12, because at 12 cents per capita, nobody believes me, so I hacked the thing just to gain the credibility, but I'm lying. 15 rupees per capita per year is our cost. We replicated this model, like I said, in 4 different districts. And we have similar results, 90% reduction in maternal mortality in less than 3 years, and 67% infant mortality reduction in 3 years at the same cost. On top of that, under the same cost, we have launched population stabilization program, and also we launched TB control program. On top of that, we just started livelihood generation program. The cost does not increase. It just adds 1 more page to the portfolio. Anybody's interested in details, I'll tell you later how it's to be done. We can all do it. It's not a big deal. The key is we had to go there. Now, therefore, the next step is primary care in NHS or US everywhere starts with the primary care doctor, so does it in Delhi. Primary care in rural India starts at the home. There's a no man's land where the demand is created when nobody ever visits. So our primary care starts from home. We do house-to-house visit. You have to detect these people who are sick because they don't want to come. A pregnant woman that I saw waddling from her because of the bad roads, where I had to take 2 ibuprofens before I reached the PHC, primary health center, because of the backache. She was waddling to a clinic which is about 7 kilometers away. For her to come to the clinic for antenatal checkup 3 times during pregnancy is a tall order. So we had to go there. So having said that, I'll stop there about the Save a Mother. I'll take the second question is Ayushman Bharat. Now, Ayushman Bharat, or for that matter, any insurance scheme in the world has 3 functions. Number 1, win the elections for the politicians. Number two is decrease the financial risk of the population. Number three is improve the population health. And the first count is been tried before many times. Bismarck in 1883 won the elections because he provided health insurance to German factory workers. Obama won the election 2010. Dr. Reddy Arogyasri in Andhra won the election 2004. And in Brexit, NHS was a political football. So it's been used by politicians before. On that count, Ayushman Bharat will succeed to an extent. They will get some votes. Number two is financial risk management. If run efficiently, Ayushman Bharat will decrease financial burdens on poor families if run efficiently and effectively. Efficiently means value for money, effective means the outcomes. So there's a possibility. The third is, does it improve population health? This is where the insurance schemes of the world have failed. I want to suggest to you the problem is the structure, the way insurance are structured. In a risk pool, money is funded, called the fund, which is then distributed three ways by three competing adversaries: the insurance companies, the patients, and the doctors or the providers. Insurance companies want to maximize their profits, so they delay and deny payment. Doctors want to make extra money, so they induce demand. Patients, because of the moral hazard of third-party payment, would want everything done to them. So on this pool of fund that you have, you can see three adversaries working in different directions. So this is an inefficient system. Can we have a system where these three entities cooperate? So the costs are taken care of from this pool of fund. Incentives are given for better behavior, including cessation of smoking and so on and so forth for the patients. At the end of the year, money then, which is the profit, is given to various parties. This can be done in India only at the district level. If you want to understand India, I've been trying to understand it for 100 years now. The only way to understand India is the district level, one district at a time. You cannot understand a state level, you cannot understand the country level. Each district is different. And a district is manageable. You can put your hands around it, you can traverse the distance of a district, which is like a county outside this India, is in 45 minutes to 1 hour. And they're homogeneous. There's one district magistrate who is to be collector under British India, whose job was to collect. He still is collecting, trust me. But then the rumor is he's the richest man in the district. But then he's the king. If you're in good books, he can manage the whole thing. So district has to be managed. I won't go into the details because it'll take extra time. Ayushman Bharat is defective in its structure. We have 140, at least 150 years of experience in the healthcare in the world. We should have adopted modified NHS of 2018 and taken it from there, done our own iteration to suit our Indian context. We haven't done it, so it's doomed to fail. Thank you.
Thanks, Dr. Ganju. Now, same question, right? We're just going to go across. Dr. Gulati, from a care perspective, you're in a hospital. Again, what are the key challenges that the government should anticipate over the next couple of years with Ayushman Bharat? And, what suggestions would you make so that we help improve the scheme?
Sure. Thanks, Prerak. I think much has already been said by Dr. Kingsland and Dr. Ganju. To add to it, I'm a dermatologist. So I see mostly patients in the outpatients. So a few of them actually are inpatients. Now, much of the hype is around providing this certain amount of money to the households per year. Now, that is largely for the inpatient care. So we are actually, what is omitting is the outpatient care. And if you look at the statistics, I don't have the exact statistics, but much of the out-of-pocket expenditure is for the outpatient care. So where does that go? That is still actually coming out of the pockets of the common man. Whatever we have actually done, do we have a robust data as to what is happening, how many of the people actually have a certain amount of diseases in certain amount of areas? So if we have a certain hike in the number of procedures in a certain area in the next year or so, is that really awareness or is that an insurance fraud? Nobody knows. So how to keep those checks and balances? So I think some kind of a measure about checks and balances as to where that money is going and how that money is going is actually is to be needed. Secondly, we have got a lot of satellite centers and we have got few tertiary hospitals. So once you actually incentivize inpatient care, just like we have done with the amount of money that has been given, people try to sidetrack the outpatient care. So if they want to get certain investigations done, say come to you and they say, sir, can you admit me for a day? Because that way the investigations go free, because they have got a booty. They've got a certain amount of rupees for the inpatient care, but they've got nothing for the outpatient care. So I think that increases the load on those tertiary services which are already burdened. So if you look at the tertiary hospitals in our country, you will see people actually trying to mend very common diseases which should not be mended there. They should have been mended on the satellite hospitals. So we need to improve our satellite hospitals. What I would say is, it's a brilliant scheme, but I would rather concentrate on those 1.5 lakh health and wellness centers that the scheme promises. And that is going to be the key point. Because if you can actually improve those, you're going to see much of your patients in those health and wellness centers, and we can attach the primary care there. So that is, we're going to come to Ayush as well, I think, in a moment of time, and you can probably integrate that into that primary care. And if you are able to actually solve much of your problems there, you will reduce the burden on the tertiary care, which is the most expensive care of all the sectors. So that is what I have to say.
Dr. Dhakal?
All are against it, I think.
So it's not a question of being for or against. I think it's India needs it. We all recognize that. So the question is, how do we fix it?
Yeah.
Trying to improve.
So, me coming from Nepal is a very unique it's not very straight for me to answer about the universal healthcare coverage Ayush does in a different country, because we come from a different country. But when I see from the developing world prospect, where we are less developed than what India is, and what we have achieved by doing something extremely new for our market, and including South Asian market, I definitely have few things to say on this. When I started my home healthcare business, which was social enterprise 10 years back, there was nothing in landscape. So think about 10 years back when in Delhi, if you needed something to be delivered in home, it was fairly free market, there was nothing. And now, down the line in 10 years, what Delhi has is in every hospital you have at least 5 or 7 brochures of different agencies, which has catapulted like a hot market, and everybody is talking about home healthcare market. So I take a pride, because I also know the people who are working like Vicky Singh and Sachi and everybody else, like they recognize that the things that we did in a small silo of Kathmandu happens to be something in a game changer in a landscape. I'll connect another dot. Is last week I got a call from a GP friend of mine from UK, and we happened to meet in a quality conference in Sweden, where actually we also met with the friends from Partners Healthcare Advisors, Healthcare Quality Initiative they run in Boston. So they saw my presentation, and this lady, she has a young son who wants to do a 1-year sabbatical in some other country because he wants to become a doctor. So she says, Bishal, can you take him up as an intern? And what does it mean? It means like something that they have in their practice. It's very close to a developing world, and it has huge resonance for her being a GP. Gives a very different perspective how different NHS community healthcare model, like public healthcare model works, plus the kind of innovative platform that we have created in a country like Nepal makes sense for them to be explored or exposed. So connecting this dot, Sweden, UK primary healthcare projects, Nepal home healthcare projects, and what Ayushman Bharat can do for India, I think it's all, everything boils down to dollar. I mean, there's a very big expert right beside me. Everyone has done a lot of work. It's anyone's pocket money that goes, like either it's government money, which is Ayushman Bharat, or it is insurance money, which is insurance private money, or like, there's a private enterprise, or there is an individual payer who actually pays for the service. If you count $1 and what you're looking at as an outcome of that investment of $1 is going to be a quantifiable value that you have to see in that outcome as a return on investment. Even government has to look into from that prospect. And what does it mean is like what outcome Ayushman Bharat is looking at the 10 years down the line? What population base it wants to cover? What kind of alternate bed scheme that it wants to create without creating a hospital, maybe a home care, maybe a primary care chain, maybe a social enterprise network. So it boils down to few of the points that I think which is going to be fundamental for our government to look into or the policymakers to look into. I would really suggest that the innovation management has to be there to be streamlined. What kind of benchmarks that the government wants to achieve with this kind of scheme, which is possible. I definitely see what Modi ji has done for his country is phenomenal, and he actually sees that the well-being of a country is important, and I think it's very, very nice that the universal healthcare has come to India. So I can dream that one day we'll also have it, because we are very much influenced by the Indian market. Second thing that you have to do is the navigation of a patient is very, very difficult. And most of the price goes down on that. So if Ayushman Bharat will have some kind of a process where you will cut down on the navigation of a patient to a right person on a right time on a minimum cost will be phenomenal. And also government has to focus on predominantly what milestones it wants to meet in a 3 phases. It can be a pre-hospital, hospital, and post-hospital. What they want to cover, what kind of packages they want to look into in phase 1, phase 2, phase 3, or whatever they design, will be a very, very precise, organized approach to look into that market. And patient access at the end of the day, the people who actually cannot come out from the bed or the kind of people who doesn't have access can be redefined from delivery of care at home to telemedicine. These are the things that probably if Ayushman Bharat can look into. That's my personal experience with my 10 years of exposure into a developing market like Nepal, which is very close to what Indian market is. And we really depend on a lot of things for expertise on healthcare, right? Delhi is our biggest hub. Like thousands of Nepali people are right now in beds in a hospital across the city. So I clearly believe that this is possible and it should be done.
So now we've got Mr. Ramani from Policybazaar. We need somebody to stand up for the insurer. So Mr. Ramani, at least to spark debate, let's talk about what are the pros of having an insurer versus a trust model. So by the way, for everybody who's not familiar, Ayushman Bharat is getting implemented at the state level, and there are 3 types of implementation that are actually happening. One is insurer-led, where a state is selecting an insurer to come and run the scheme for them. Number 2 is a trust base, where the state is putting together a trust out of which they'll pool in the funds and actually pay out the funds. And finally, there's a hybrid, which is a cross between an insurer and the state coming together. But, you know, we need somebody to stand up for the insurers. So what value could an insurer bring into a state versus having a trust model?
Thank you, Prerak. I go back to what Dr. Ganju said. There are 3 stakeholders in the system, and each drawing their own ways forward for their own maximization. And as good a scheme as Ayushman Bharat, it's a great start, and I think it's a way forward for us. We have to go back to the fact that the other 2 stakeholders still exist. There's still a private enterprise, there's a hospital that's going to exist. That's the whole desire of the scheme. There's a customer who's looking for more and more maximization of what he's been given free or otherwise. You will still need the third leg, the third leg of the tripod to balance the whole scheme there. In the long run, the sustainability of a scheme is very important to keep it running, to keep it worthwhile for all the stakeholders involved. And without the third tripod of insurers getting involved, things may be different. So while I'm here to bat for them, it's also to generally put forth that they are not just there to maximize their own criteria. In the process of doing so, ultimately an insurer is a profit-driven enterprise, so obviously they will try to maximize their profit. But in the process of doing so, one has to always look at and appreciate what they bring to the table. There's a lot of efficiency brought into how claims are handled. There's a lot of effectiveness done, effectiveness outcomes that happen because there's a lot of data that's analyzed by an insurer to see what's effectively going to a customer. Does it solve their problem? Was those procedures really required? Could they have been handled any differently? Is there a case of certain kind of procedures being abused? Look, we've had in the past similar government schemes that I've run, state schemes, RSBY, take any of them, even the CGHS or the VHS. One can obviously understand the fact that there is a lot of inefficiency that runs in there. Call it fraud, call it spread, call it any other means. There is a lot of things that can be handled better. And this finally boils down to sustainability of the scheme. We are talking about Ayushman Bharat, where we are looking at an initial outlay of just about 10,000, 12,000 crores. That's no means, that's just twice the outlay of what RSBI had at last count. That's no means a great amount of money that's been put on the table to run this show. You will need a lot more efficiency to come in. An insurer, the sector coming in and playing in the game with their expertise that they've gained in the last 6-7 years around RSBI and some of these state schemes as well, is what could bring about more about efficiencies to the scheme, could make the scheme more effective. Besides this, now one can talk more and more about the efficiency and effectiveness, but I'll leave it there. One has to also look at the fact that bigger schemes in the world have succeeded because they have been successful in bringing more people on the table, sort of energizing the whole space, energizing more and more stakeholders, energizing a lot of different related entities to go for it and to make it a success. If the scheme is going to be run as a purely government initiative, more in the trust model, and I hope not, it's going to be more unidimensional. That's just going to be one entity, one agency which is working, and it's going to try and talk to you more and more that it's actually working in your favor as a customer. By just bringing in more and more entities, you're going to energize more and more people talking about the goodness of the scheme. More people who are going to take it down to the ground level. See, ultimately, you want us to also understand and appreciate that insurers bring efficiency on the ground in terms of claims handling, which is their core. They also have today been able to bring a lot of distribution efficiencies. They are there to run distribution on the ground. Between the private insurers and the public sector enterprises, they today cover a lot more villages across the world, across India, and they have some kind of a distribution setup there. This is all for the taking. If you really want to take the scheme to the grassroots, one has to leverage every node available. And I think the insurers can bring in a lot more game here and make the scheme an overall success. Not just the short term. I think in the long run, they can bring in a lot more capability that a government entity may not find space and capital to invest into. And I think therefore, it's a great start. It's a great start. Ayushman Bharat is a great start, and I hope somewhere we are able to see more and more private and public sector insurance entities participate in it going forward.
Thanks. Now, switching gears a little bit, because the panel is about a little more than just universal health coverage and Ayushman Bharat. So, Dr. Ganju, there's a lot of work going on in India in terms of Ayush itself, which is different from Ayushman Bharat, but Ayush. Would love to hear your perspective on key challenges, key opportunities for Ayush in India over the next few years.
Before I go into Ayush, I want to spark it up a little bit, even if it may be controversial, just one-liner. Commercial healthcare is toxic to healthcare. Irrespective of what my friend said, and I took his permission that I'm going to create sparks, please don't fall for the glib talk. I worked in a country for 45 years where 50% of the healthcare is the commercial insurance, which is United States of America, and it's a disaster. You don't want to go that way. The most efficient part of insurance in US is Medicare, where admin cost is 5 to 10%. And in commercial insurance is anywhere from 30 to 50%. So much so, the Obamacare had a clause in the law that 80% of the premium will be spent in healthcare, only 20% on the admin and profits. It didn't work because there's a whole lot of gaming this system going on. So please, let's not fall for that. Unfortunately, the only known game with evidence-based is tax dollar, tax rupee, paid universal healthcare run by the inefficient, ineffective governments of the world. So be it. If we can improve on this somehow, and there's hope because of the IT structure that we have now, can make many things redundant administratively that were caused inefficiency before. Having said that, Ayush. Ayush is interesting. Ayush is hyped up. Ayush is touted as the panacea of everything. Now, Ayush is, those of you who are not familiar with it, Ayurveda, Unani, Siddha. 3 systems. Sorry, homeopathy, sorry. I forgot another scam, homeopathy. Sorry. So there are 4 of them together, mixed together, will improve your health. Answer is there is no evidence. The problem is the following. I'll tell you a little story. one of the biggest families that works in this field. I was traveling with a person in the aircraft. He was with me, and what do you do? He says, we run this company. I said, must be huge, etc. And I said, do you get all your products from Charaka? To bring you up to date, Ayurveda is based, 80% knowledge is in 3 books, Charak, Surshrat, and Vagbat. There's the folklore, which is the other 20%. Charak is the main person who gives you all the recipes that you have. So the gentleman next to me, multi-billion-dollar business, he says, who, Charak? So I shut up. I didn't want to say any further that this is the state, the man who makes his money from the pioneer genius of a person that we had in 100 BC 80, that era, didn't know who Charak was, who makes his family money. So we got into the act. That is, we started a group, and that's where it comes from. Can we take Ayurveda forward? Can we use modern tools to analyze what the ancient people did? Basic principle, plant kingdom has been here for at least 1 billion, if not 2 billion years. Biggest pharmaceutical company, Merck, started 190 years ago. So man, who's a product of evolution, nature, has had only 190 years to produce molecules, while the nature, Mother Nature, has done it 2 billion years. To me, it's a no-brainer. The Mother Nature has produced more molecules. The key is, can we look into it? And we have a 5,000-year-old tradition of doing it. Ayush has 2 systems. One is the mind-body, it's 2 tracks, 2 strands. Mind-body medicine, yoga, and so forth, and also the phytochemicals, the plant-based chemistry. Now, they didn't call it phytochemicals, they call it jadi booty or roots or whatever you want to call it, but it's phytochemicals. So the idea is find phytochemicals in the plants and use them for therapeutic supplements or whatever you have. The point is, can be done. We've been doing this for 15 years. We have the largest, I want to repeat it, the largest phytomolecule library in the world our group has created. We have close to 239,000 phytomolecules in our library. And we're working every day to produce NC, which is new chemical entities, new drugs, et cetera, and we hope to give one within the next year or 2 to the world market. And the key is, so far the paradigm in pharmaceutical is 1 receptor, 1 molecule. That's the way the patent regime is set up. It's highly biased. Can there be multiple molecules or multiple receptors that could be used as 1 drug? That's what Ayurveda has done, or for that matter, folk medicine has done. This system of breaking the dogma is not acceptable at the moment. Hopefully, when the TCM, the traditional Chinese medicine, Ayurveda, gain political strength, we'll be able to change the patent laws of the world. Still, we are struggling to find 1 molecule, 1 receptor. To me, that's a disaster. That should not be the way to treat human body, because for any given function of the human body, there's not 1 receptor, 1 molecule equation. Thousands of reactions going on as I'm talking to you in my body to maintain my balance, both body and mind. So you need 1,000 molecules to attach 1,000 receptors for me to continue functioning and be sane while I'm talking. So what does Ayush do now? Where is the role of Ayush? At the moment, role of Ayush is treating people at the primary care level for self-limiting diseases. 80%, I can tell you as a doctor, 80% of diseases, maybe more, are self-limiting. You don't need a doctor. But then you need somebody help, somebody with compassion and so on. He can use Ayurvedic medicines or homeopathic and so on and so forth. The person is going to get better anyway. The rest of the 20%, nobody knows how to treat and cure them anyway. So they go to a tertiary care hospital, we operate, we cut, we mutilate, we do radiation, we do chemotherapy. That's the business side of medicine where we doctors make tons of money. So can we then improve on Ayurveda, so to speak, and give you these phytomolecules which will improve the self-limiting diseases, and maybe from 20% we go to 30% or 40% category? Is it possible? Answer is yes. Why I'm talking about this? Because we have succeeded in doing certain things so far. In terms of IPR, we have something like 37 IPRs. Only yesterday I got a call that we have on 2 NCEs, which may be publishing, one for diabetes, one to replace monoclonal antibody, etc. So the idea is it's possible using modern tools for ancient wisdom and move forward. This is only for Ayurveda I'm talking about. I'm not talking homeopathy. or Siddha medicines, which is beyond my pale of knowledge. Thank you.
Thanks. That was good. So, on one side we've got medicine that's been around for centuries. On the other side, let's talk about the other form, digital health, right? So, Mr. Ramani, how can digital health in India help improve access to care and quality of care? Policybazaar has been doing a lot of work in that area. Maybe you could tell the audience a little bit more.
I refer to the keynote session we had, and a lot of what we've been speaking, that real effective way to manage population health levels is to actually get to the primary care. Make sure that you handle the issues as and when they arise, instead of letting it grow to a level where it has to be handled only on a tertiary care. And at least from an insurance and a distribution perspective, the last mile was and continues to be a problem in India in terms of accessibility in a lot of places, and wherever there is accessibility. So probably in urban areas, I think accessibility is not an issue. You find a neighborhood doctor almost in almost all good urban areas. But then the ability to go and consult and take advice for niggles, as I'll call it, which tomorrow can lead to something bigger, is lower. So there is both sides of the coin, that there is an accessibility issue and there is a willingness and acceptance issue of going and taking support. What we as a group are looking for, obviously there are models around the world on how to solve this, and digital model has been successfully at least used in one big market, which is neighbor to us in China, where the digital health model has been fairly successful in making sure that a lot more people have access to health, primary healthcare health, and are getting remote help. So that was exactly the model that we saw, and we are entering the digital space where we believe that by providing access through a remote connection, which is through any device you hold, through an internet, if more and more people can be brought closer to nodes that can deliver the medical care. So it's a simple combination of what you call as a telehealth care, or what you can call as doctor over a chat, finally culminating into potentially what we call as a doctor on video. So digital health, we believe, can therefore help cross that last mile and help people more and more open up to the idea of what care they require, where we can intervene and suggest what is the best mode, what is the best step to take in order to handle a given issue that a customer residing in any part of India is going through. Now, what is obviously helping at this point in time is we are going through the revolution where data and accessibility to internet is growing day by day. It is still not up to the level that you would want. It is still not up to the level where the neighboring China today sees it, which has been a great enabler to do that. But it is definitely seeing a big turnaround in the last 12 months, thanks to some of the initiatives that have happened on the ground. We therefore see this is the right flux where digital health can substitute what else is happening on the ground to drive that primary care in a more efficient and effective way to the customers on the ground.
Mr. Ramani, because we're running short of time, I want to make sure that I come really quickly to Dr. Kingsland too. So Dr. Kingsland, with NHS, integrated care, let's take a different perspective, integrated care. Let's talk about digital and physical. What's happening in the US? What can we learn in India? What's NHS adopted?
Well, we talk about integrated care. I think I'm up to my 66th definition of integrated care, depending on which sector is looking at it, whether it's primary, secondary care, or is it health and social care, is it digital care? So probably one of the things I'd say that's really important for integrating care, going back to my presentation about the wider determinants, I'll come back to the digital issue, which I think is really important and probably hasn't been discussed enough about the investment, or the modest investment, I say modest, for Ayushman Bharat, about how that could be utilised. Because there's one thing that I have noticed that citizens of India most will have a mobile phone, and the ability to consult, use that to get accurate information. But on the wider determinants, I was looking at some of the figures that of the environmental or avoidable environmental risk factors. That caused about 13 million deaths. A quarter of the global burden of disease is related to environmental factors, some of which I was talking about it in disaster medicine. So if we're going to integrate care, we've got to think outside of just the health model, the issues that determine whether people might get unhealthy, and address that as part of a holistic way of delivering an integrated service. But I think that going back to my 66 definitions, it is all of it. It's got to bring in the social aspects of care, the digital AI that's available now to allow people to access healthcare through a different medium, as well as a range of services that can be delivered in a primary care setting.
Perfect. Thank you. Dr. Dhakal, really quickly, you've got an interesting product, the care home service. You ended up launching it in Nepal. I'm sure you try to go to a few different insurers and tie up with them, right, for chronic disease management programs. What happened? What was the interaction like there? Have they signed up?
Well, I mean, Nepal's very, it's a very poor country, frankly. I mean, but the insurance market, especially in the developing world, is very slow on adapting home healthcare products as a enabler. Recently, I was in Istanbul and I was sharing a panel with Allianz CEO. Allianz, they call it Sigorta. So they have an innovation team, and I shared my, because they wanted to talk more about it, know more about it, like I'm sitting with him and we're talking really warm. It's like they understand the bandwidth because it protects the interest of dollar value. I mean, whoever the payer is, it doesn't matter. But at the end of the game, I mean, what we've been able to convince, at least in developing world, is there is a value for individual payers' protection. What does it mean? That people who doesn't have to go to the hospital or who can benefit not going to the hospital can actually benefit better by staying in home by 3 times protecting their money. And it is as profound. I mean, you don't have to have an insurance. It's just like if you protect money of his, or it's his or yours, it doesn't matter at the end of the day. It is basically protecting the value, and that matters most. I mean, that's the very important value that we probably miss out usually designing a business. So for health at home, what we do in Nepal, or for example, if we do in somewhere where it is insurance matured, or for example, if we get an opportunity to do with the NHS in UK, our interest is profoundly based on protecting that dollar, and it works well. So, I mean, some of the insurance payers, like for example, we do sometimes expat clients services, they pay it easily. They're very welcoming. And sometimes we also have Nepalese people who are insured in a standard insurance like MetLife and other things. We pay, and we are actually signed up with 7 insurance companies recently. This is like a 1-year development because insurance has boomed in Nepal as like new financial market. And they have signed up us for doing a preventive checkup. Like they send us in a home as a privileged client and we do it. So it's very nice process. I think 80% of the healthcare dollar value business will be in home. What James said is actually, I totally agree. And from where we come from, the knowledge base of healthcare, where we miss out most of the things, is protecting that every penny or every dollar. That will be important.
Perfect.
Yeah.
Thank you. One last question before we open it up to other questions from the audience itself. Dr. Gulati, really quickly, you've been able to implement some interesting shared care practices as a part of your practice itself, right? If in a few sentences you could quickly describe it to the audience, and also what kind of outcomes you've been able to see.
Thanks, Prerak. I'll be very quick so the audience get their part. I think having worked in UK for 9 years, from where Dr. Kingsland comes as well, and having working here for the last 5 years, I try to get something good from that system that we can implement here. So there, working as a consultant, we used to actually we used to interact with GPs with special interest in dermatology. So if I'm working as a consultant, then there are certain GPs or general practitioners who are working in the periphery and they have a special interest in dermatology. So certain patients, they can actually see their GPs for a few times before they come to us. So the number of visits to us reduce. So for example, if I'm giving some kind of a toxic medication for which I need blood monitoring every few days, then that can be done in the periphery by somebody who is actually able to do it. And then they can probably visit me only once in a while. So same what we are implementing here is you can't really actually do this with GPs here because the general practice standards are not to that extent. When we say general practice in India, it is MBBS. So at that level, we can't actually just leave the patient to them. So what we are trying to find is dermatologists who are in the periphery. So once a dermatologist goes into the periphery and settle, they leave the academics to a great extent. So they're not following that. They don't have provisions for good diagnostic workup. So that is what we do for those patients. We come to a diagnosis, we implement the treatment, and then we say, you go to that particular dermatologist because he is very near to you or she is very near to you. So they can actually go there maybe monthly, and maybe just 4 to 6 months they can come back to me. So rather than coming from 500 kilometers every month, now they're coming in once, maybe 2 or 3 times a year. So that's kind of a shared care. And what that is doing is, it's actually giving the tertiary care to a person in the periphery with minimal expenditure. So I think that reduces the cost overall of reducing the tertiary care and reduces the burden on the tertiary hospitals as well.
That's fantastic. I think, there could be a lot of companies that come up that focus on specialist areas like this and actually build solutions like this for the market itself. So we've got a few minutes. Let's open up to questions from the audience. Please keep them short. Yeah.
I have a burning question. My name is Preeti Rao and I run a company called WellG. First of all, I find myself in great sync with Mr. Ganju and Dr. Gulati with not sugarcoating the reality, what is in front of us. My question is for Mr. Sethi and Mr. Raman is with respect to insurance companies. So far the new healthcare pyramid talks about that the top 5% of the healthcare pyramid is somebody who actually needs acute care, hospitalization. The next 20% are people who actually need a doctor's intervention, but probably can also get help from nutritionists, fitness trainers, and health and wellness coaches. The 70 to 80% who are at the bottom of the pyramid are people who are fairly healthy, but probably would need just practitioners, health and wellness coaches who can help them to continue staying healthy. So the current healthcare system, the way it is designed, fosters sick becoming more sick and really not focusing on the health of individuals and the society at large. So my question is, when are we going to start incentivizing people for staying healthy? And when are we going to start incentivizing people for cultivating healthier habits? And when are we going to get nutritionists, fitness trainers, health coaches, alternative medicine practitioners like in the West are covered under insurance so people can actually go out and reach out to them?
So if you don't mind, let me start off by this actually, because it's a topic near and dear to my heart actually.
Thank you.
So interestingly actually, an insurer is completely aligned with a customer once they bought a health insurance policy from them, right? Really what they want to do otherwise is keep them healthy. And in case there's a healthcare incident that happens, what they want to make sure is they get the best treatment with the best outcomes as quickly as possible, right? Get them to the right doctor, make sure readmissions are lower. And then after that, in case, you've got a population pool that you've built up in time and there are certain disease profiles, chronic illnesses that are built up in your population pool, what you want to do is you really want to manage them itself, right? So actually, interestingly, an insurer is the one who's completely aligned with the customer to make sure that they get the best treatment in healthcare after they've been signed on as a customer itself. Now, what does that actually translate to? It translates to a couple of things, right? So in India, what's happened is as the health insurance industry is actually developed, they've started with the piece which is in the mind of the customer the riskiest, which is the inpatient coverage itself, right? So what the customer is worried about first is health protection. They're saying that, hey, how am I going to afford the 20 lakh rupee incident when it happens in my family? How am I going to afford the cancer, in case it comes out? How do I afford for that? So that's been stage number one where insurance is really pushed within India. I think stage number two is coming very clearly. Some of the standalone health insurance companies such as Aditya Birla, Apollo Munich, they've started talking about prevention and well-being already. And some of them have already started looking at disease management programs like Max Bupa has, right? And they're saying, look, how do we bring them to India? The issues turned out to be the customers from the other side say, look, I don't want to pay an additional premium. So that's actually the challenge that they grapple with on a daily basis. But I think we'll all agree OPD is here now, right? Even from a private health insurance perspective, every health insurer that we work with today is saying OPD, yes. So nutrition is going to be a part of that, diet's going to be part of that, doctor consultations, pharma drugs, everything is going to come under the gamut of insurer. Insurer really does two things on behalf of the customers. One is they clinically validate, right, the service they're bringing to their customers. That's an important role that they play. Second is they negotiate like crazy, right, with the care provider. But with the care provider also, that's a good thing because sometimes that brings stability to their business itself. So, yeah. Any other questions?
I had a
Sure.
question and maybe I'll start with a comment. Biten Kathrani, I'm the head of R&D for the Asia Pac region for Boston Scientific. And I had a comment similarly on the insurance side. I'm going to pick on Mr. Ramani. Sorry for putting you on the spot again. I want to start with my comment
can we, instead of comment, can we have a question, please?
Well,
Or
unless I make my comment,
short?
I'll
Yeah,
keep
can
it
we
short.
the
I won't
comment
make it
short,
long.
please? Thanks.
My comment is, you mentioned about the biggest value which the insurance companies are adding is the efficiency in the claims. And I would beg to differ on that, because that's where I align with Dr. Ganju. The third parties, the TPAs are actually doing that process. And with due respect, the only mindset they have is delay and deny. But someone like you, which actually is now getting into that intermediary aggregator, which is very different than the TPA model. Could you reflect a little bit on what type of data are you seeing from customers who are buying insurance from you? And how do you, in this world of artificial intelligence and machine learning coming into play, do you see changes coming?
Yeah, I think you hit the nail there. It's not just us intermediaries, digital intermediaries like us who are working on the artificial intelligence. It's also a lot of our partner insurers who are also getting into the game. A lot of efficiency I spoke about on claims, as you rightly said, traditionally have been handled by TPAs. We have our own viewpoints on whether it has been great or wrong. But the real picture, the real benefit that's going to come in the future is when insurers on one side, digital intermediaries like on the other side, are going to get more and more data of the customer, right from his daily care to when a tertiary event happens, and then leverage artificial intelligence on this to make sure the whole system end-to-end is more effective. On paper, yes, that's the game. Like we always would want to believe, all the entities are working towards that. Now, in the how it will roll out, who's going to be the beneficiary, I think the other entities, the other stakeholders in the system have to make sure that all our goals are aligned so that nobody runs out with one entity runs out with all the meat in the game. But then that's exactly where the benefits of an insurer can come in, or enterprise like us can come in, where we're seeing a lot of data. So to be honest, even today as we are seeing 6, 7, 8 years of customer data is good enough to start predicting who's the kind of customer who's going to need a tertiary event, who's going to have a tertiary event coming up in next 18 months, and can you intervene something to stop that from happening or make it less severe. So definitely it's on the game. It's early stages in India as in the rest of the world, but that's exactly where the market is headed.
More questions?
My name is Basaraj Gani, working in Oriental Insurance. For your information, in medical sector insurance, we are under loss 167% for your kind information. We are not profit motto, we are servicing motto. For your information.
So that's not even sustainable. That's actually not a question, and that's actually not sustainable. We work with Oriental, and I called up with the gentleman on the way here, and I said, "Sir, you're not passing my client's claims. This is not going to work out."
Oh, this is for information, I will tell you.
So the service model doesn't work. You're still Oriental. It's a PSU. It's a Government of India entity. Yeah. You're though still a for-profit entity. So it's not about forced service and passing claims. That's actually not the motivation. I think the approach that health insurance should really take in India is again going towards preventative well-being, improving outcomes, clinically validating, improving, negotiating with care providers so that actually at the end of the day, better quality care, better access is given to customers. That's effectively what it's about. Thanks.
Thank you.
Other questions? Okay, good. So I think Ayushman Bharat is going to keep us all busy. The headlines are going to keep us all busy. Dr. Kingsland is going to read about this giant scheme that's kind of getting launched. We're all going to talk about it at dinner parties for the next few years, especially everybody who's in the healthcare sector, right? This is going to impact every single one of us and significantly. So it's really up to us to actually turn back to our government, our state governments, and tell them how the scheme is behaving, right? So it's crucial for us to actually change the structure, especially from within this community. A lot of ideas can come together. They should go to the government itself. So I'd like to thank everybody on this panel. Thank you for coming together. Thank you for making this interesting. And the audience, thank you very much.
Thank you so much. Prerak, I have some comments on that as well. I think fraud is something that we will have to really look at it when it comes to Ayushman Bharat, because I'm sure there'll be mushrooming of a lot of middlemen now who would be actually, if a person has pain in the abdomen and he goes to a hospital, the hospital will say, let's do an appendicitis operation for you. You take away some of the booty from what would be getting. So for the poor person, he would be selling off his appendix at a point of time. And maybe that is something that we really need to look at when it comes to Ayushman Bharat. Secondly, when it comes to Ayushman Bharat, we say that the PHC would be the one that would be giving out cares. At present, the situation analysis says only 15 to 20% of the needs of the community health needs are actually met out by the primary health care, because it's skewed towards pregnancy care, it's skewed towards neonatal care, and it's only skewed towards communicable diseases, whereas the larger chunk of diseases are the non-communicable diseases which are still missed out. And the third point that I feel is Ayush has been completely missed out from Ayushman Bharat, though we have a complete ministry sitting there, and yet we have kind of completely ignored Ayush from Ayushman Bharat. So I would, if you have some comments, I would be happy to
So
listen
just
to
on the
that.
fraud, because that's interesting. I think we were all talking about the fraud earlier. So this is anecdotal, but in the private health insurance sector, by the way, when I sit with everybody within a community, they say in India, this is anecdotal, by the way, they say the fraud's between 10 to 20% today. Now, it's crucial for us to catch fraud, catch waste, catch abuse, right? Within health protection team, whether it's a trust model or it's an insurer-led model. And the reason is that eventually, it's actually the good policy holder, right? It's actually the honest citizen who ends up paying for that fraud. So it's more than the government wanting to do it. It's actually a responsibility to catch.
Actually, I think
fraud.
there's something has to be done to actually control the fraud there. So thank you so much for the lovely session. It was lovely hearing to all our panelists as well. So if we could, I could request Prerak to please give a memento, token of love and appreciation to all our panelists as well. So if we could start with Dr. James P. Kingsland. Thank you so much for joining us today. It was a pleasure having you here. Thank you so much. May I request you to give it to Dr. Ram Gulati. Dr. Shiban, I'm skipping you completely. To Dr. Bishal Dhakal. Thank you so much for joining us here today. Thank you. And last but not the least, Dr. Vaidyanathan Ramani. Thank you so much. Instead, can I request you, Dr. Shiban, to please present a memento to Prerak as well. Thank you so very much. Thank you so much. Thank you. So we would now break for the much awaited tea session. So if we could quickly grab our teas and come back for the next session, which is Innovators, Pictures and Award. Thank you so much. Thank you, all of you, for joining us today here and sharing your experiences with us. Thank you so much.